So I said I promised you guys 2 videos today, so this is indeed the second video. Let's talk about intracellular accumulations as a last part on cell injury, and we shall move on to the next chapter. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review series. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at intracellular accumulations. If you haven't yet subscribed to the channel, hit the subscribe button, hit the bell notification icon so you never miss on such amazing content every time I post. Grab a piece of paper, grab your pen, and let's go. Don't forget to tell a friend that we are covering basic sciences on this particular channel. So in the previous videos, we looked at cell adaptations, cell injury, and cell death. I will leave the playlist tagged at the end of this particular video. In this video, we will look at intracellular accumulation because different substances could sometimes accumulate in these cells. You may have glycogen, you may have things like calcium depositing in living cells, depositing in dead cells. So remember, under some circumstances, cells may actually accumulate these abnormal amounts of various substances, which some of them could be harmless, some of them could be causing varying degrees of injury. For example, you get iron depositing in the tissues as hemosiderin. If it's not in large amounts, it may not be so much of a bother. You get a lot of it depositing in tissues like the pancreas, in tissues like the liver, in tissues like the heart. This could actually cause problems. So remember that these substances may be located within the cytoplasm of the cells, typically within the organelles, typically within the lysosomes, or it could be in the nucleus, or it may be synthesized by the affected cell, or it may be produced elsewhere. The substances are going to be largely divided into 2 main groups. You have the normal cellular constituents, it could be water, lipids, or proteins, or it could be abnormal substances, which could either be endogenous or even exogenous. And the substances are going to be accumulating either transiently and they're going to be removed, or permanently, meaning that they're going to last there most likely forever. So there are 4 main pathways of which these abnormal intracellular accumulations actually come into play. One is because you're not adequately removing the normal substance by these secondary, or you're not naturally moving these substances because there are some defects in mechanisms like packaging or even defects in transport of things like, for example, with fatty acid change in the liver. There's a problem in the synthesis of those lipoproteins. So it means that fat begins to accumulate in the cells of the liver. Or number 2, it could be an accumulation of these abnormal endogenous substances because maybe there's a genetic defect or even there's an acquired defect, maybe in folding or even packaging or even transport or even secretion, or as with certain mutations like, for example, alpha-1 antitrypsin. Remember, I already talked about this. It often tends to cause a severe form of emphysema that is known as pan-acinine emphysema. It's also going to be associated with liver cirrhosis. The third type is known as failure to degrade a metabolite due to maybe an enzyme being absent in the body. This is very common with storage diseases. The fourth type is because of deposition, even accumulation of these abnormal exogenous substances when the cell doesn't have the enzymes that it needs to break down this material to degrade this substance, or it doesn't have the ability to transport it to other sites. For example, if carbon accumulates or even silica accumulates, this is an example of this mechanism. So those are the 4 pathways in which these intracellular substances actually deposit in various cells. The first thing that I'll talk about is fatty change or steatosis. Remember that this is abnormal accumulation of these triglycerides within parenchymal cells. So this is most commonly seen in the liver, but you can also see it in other tissues like the fat. The other tissues that are responsible for fat metabolism, so things like the heart, things like the skeletal muscles, things like the kidneys, and many other organs. It's going to be caused by certain toxins. It can be caused by protein malnutrition. It can be caused by diabetes mellitus, obesity, and even anoxia. Remember that it's commonly seen in our setup, especially in terms of alcohol. It may also be associated with diabetes. That's often associated with obesity. And these are going to be the most common causes of fatty changes in the liver or a fatty liver, especially in industrialized nations. It's going to be resulting from entry or defective mechanisms and even in the export of the lipids in the liver. So the liver is going to be enlarged, and the organ is going to be enlarged. The cells are going to have these clear vacuoles of lipids on them. Then we may sometimes have cholesterol and cholesterol esters that are going to be depositing. This is because remember that cholesterol in the cells is going to be metabolized, and it's going to be tightly regulated to ensure that you have the normal cell membrane synthesis without any significant intracellular accumulation. Sometimes phagocytic cells may actually become overloaded with lipids like triglycerides, cholesterol, and even cholesterol esters in several different pathological processes. One of these that is very important for you to keep in mind, which we will discuss later on, is atherosclerosis, where you have deposition of these atheromatous plaques in different blood vessels, for example, in the coronary vasculature of the heart, that can block the blood supply to the myocardium of the heart and lead to a myocardial infarction. In terms of proteins, remember that these are going to be synthesized in the cells for many different purposes. Morphologically visible protein accumulations are actually less common than the lipid accumulation, so you are more or less going to see a lot of fatty change than you are going to see of these proteins accumulating, because proteins are like money, they're like gold. They tend to be broken down, they tend to be recycled, they tend to be used up. But it may occur when you have this excess that is presented to the cell, or if the cell can actually synthesize excess amounts of this protein. So the intracellular accumulation of the protein is going to be appearing as droplets, vacuoles, or even aggregations. For example, in the kidneys, you may have trace amounts of albumin that are filtered out in the glomerulus, and they're normally going to be reabsorbed by a process as known as pinocytosis, or cell drinking, in the proximal convoluted tubule. So in some disorders where you lose a lot of protein in the urine, like for example in nephrotic syndrome, where there is heavy protein, about more than 3.5 grams of proteins that are lost in a day, because there's a problem with the filtration barrier, there's a problem with the glomerular filter. So there's going to be much of the proteins that are reabsorbed into these cells of the renal tubules, and this reabsorption of the proteins and the vesicles that are containing the proteins are going to accumulate in these cells, such that they'll appear as this pink hyaline cytoplasmic droplets. So remember that the process is reversible. If the proteinuria stops and the droplets are eventually metabolized, they'll disappear away. Another example is where you have this accumulation of these synthesized immunoglobulins that occur in the rough endoplasmic reticulum of plasma cells that are forming these round eosinophilic bodies, which are known as Russell's bodies. Some proteins could accumulate, misfolded proteins could accumulate and cause diseases like Alzheimer's disease, which is a degenerative disease of the central nervous system. And then sometimes it could be defects in the intracellular transport and even secretion of certain proteins, for example, in alpha-1 antitrypsin deficiency. Glycogen could also sometimes accumulate. So remember, excess intracellular deposits of glycogen are often going to be associated with problems in the metabolism either of glucose or problems in the metabolism of glycogen. Diabetes is a good example of a disorder of glucose metabolism. We'll talk about diabetes when we look at the endocrine chapter. But remember that in patients that have poorly controlled diabetes, then you're going to have this abnormal glucose metabolism. Glycogen is going to accumulate in the renal tubules, it could accumulate in the cardiac myocytes, it could accumulate in the beta cells of the Langerhans. Remember that this glycogen could also sometimes accumulate in the background of these rare genetic disorders, which we rarely see in our case here, which are known as glycogen storage diseases or glycogenosis. Remember, these can cause cell injury, they can also result in cell death. You may sometimes have certain pigments, which are just these colored substances that are either exogenous, for example, carbon, or it could be endogenous, things like lipofuscin, melanin, or even certain derivatives of hemoglobin that may sometimes deposit in certain cells. These pigments could either be endogenous or they could be exogenous. Most common exogenous pigment is carbon from coal dust. Remember, carbon is found everywhere. It's a very common air pollutant, especially those that are living in urban areas. And once you inhale this carbon, the macrophages are going to attempt to phagocytose this carbon, but they don't have the enzymes that can break down this carbon. So they're going to persist in these macrophages, and as these macrophages are moving through the lymphatic system, they reach the lymphatic lymph nodes. This pigment can sometimes aggregate and can sometimes even darken or blacken the lymph node that is draining, and even the pulmonary parenchyma can sometimes be darkened in a process that's known as anthracosis. In terms of lipofuscin, this is just simply a wear and tear pigment. It's this insoluble brownish yellowish granular intracellular material that is going to be accumulating in these various tissues like the heart, the liver, the brain, because the cells are aging, they're undergoing atrophy. It's going to be just these complexes of lipids and proteins that are often going to be derived from the free radical catalyzed peroxidation of the polyunsaturated lipids of the subcellular membranes. In large amounts, they may actually be referred to as brown atrophy. So this is what the lipofuscin actually looks like. As you can see, this yellowish brownish deposits that you can see in the myocardium. That's what we see as lipofuscin. Here we can see that they are around this nucleus, this perinuclear intralysosomal location that we can actually see. We see that this lipofuscin is depositing in these areas. So this is under electron microscope, this is under light microscopy. Then melanin is what actually gives your skin the dark color. So it's an endogenous brown-black pigment that's going to be synthesized by cells of the skin that are known as melanocytes. And these melanocytes are found in the epidermis. They're going to be pretty much accounting for about 10% of the cells of the epidermis. They act as a sunscreen to prevent ultraviolet radiation from harming your cells, and adjacent basal keratinocytes actually in the skin can accumulate the pigment, and you may develop things like freckles, as can the dermal macrophages. Another pigment is known as hemosiderin. This is just simply a hemoglobin derivative. That's a granular pigment that is golden yellow to brown and sometimes can accumulate in tissues. And this usually happens when you have local or even systemic excess iron. So iron, nothing should be taken in excess amounts in the body. It creates a problem. The iron is normally going to be stored within the cells, bound to a protein that's known as apoferritin. And then it's going to form these molecules that are known as ferritin. So iron is stored as ferritin. This ferritin can be recycled, so it's a good storage form of ferritin. Now, hemosiderin is this pigment that's going to result where you have these larger aggregates of these ferritin micelles, and then this hemosiderin actually is pathological, and small amounts of this pigment is actually normal if you look at the mononuclear phagocytes that are responsible for breakdown of red blood cells in the bone marrow, in the spleen, in the liver, when these red cells are aging and they're being degraded. But sometimes you may have this hemosiderin actually depositing in many of the tissues, resulting in hemosiderosis. And then if it's actually much more extensive, iron can deposit in many tissues in a condition that's known as hemochromatosis that may lead to damage of various organs. In terms of calcium or calcification, it may be pathological. So remember, the common process in a wide variety of disease states, you may get this abnormal metabolism of calcium. And these calcium salts, together with small amounts of iron, magnesium, and other minerals, can actually deposit in certain tissues. So remember, if calcium deposits in tissues that are dead, we refer to this as dystrophic calcification. And then it usually is going to be occurring even in the absence of someone having a problem in calcium metabolism. So they may have normal levels of calcium in their bloodstream, but just because tissues are dying, they have a lot of these fatty acids that are being present in that area. And remember, these are going to be attracting calcium through the process of fat saponification, which I talked about in the previous video. This is going to result now in these tissues being calcified. So we can actually use this, especially on imaging, to tell if there are cells that had died. For example, in terms of granulomas in the lungs, they may sometimes even calcify. Then sometimes if you have a disease state where someone has problems in the metabolism of calcium, they may have a hypercalcemia, where there's increase in calcium levels in their bloodstream. This calcium could sometimes even begin to deposit in normal tissues. We call that as metastatic calcification. Remember that hypercalcemia is not a prerequisite for dystrophic calcification, but if a patient does have hypercalcemia, it may actually worsen the dystrophic calcification. So in terms of dystrophic calcification, like I told you, it's going to be seen in necrosis of any type, and it's virtually inevitable, especially in atheromas of advanced atherosclerosis that are going to be associated with this injury in the intimal area, especially in the aorta, even in large arteries, and you may get this accumulation of the lipids. It may be an indication that there may be some past injury. Like I told you, you may have calcification that can develop in aging or even in damaged heart valves, resulting in compromised valve motion. And then these dystrophic calcified aortic valves sometimes are an important cause of aortic stenosis, especially in elderly people. In terms of metastatic calcification, it often happens in normal tissues. So it may be in the background of a hypercalcemia. Remember the different things that may cause hypercalcemia. It could be because you're producing a lot of parathyroid hormone. For example, there's a tumor of the parathyroid hormone that's producing parathyroid hormone related proteins, by even other malignant tumors, or even just producing parathyroid hormone. It could be destruction of the bone. Remember that this may be in the background of tumors, it may be in the background of diseases like Paget's disease, it may be in the background of immobilizing other tumors, or other immobilizing tumors, or rather tumors and immobilization, where there is increase in bone metabolism. The bone is being broken down, it's releasing the calcium into the bloodstream. It could be in conditions like multiple myeloma, leukemias, or even diffuse skeletal metastasis. It could be due to vitamin D related disorders, for example, vitamin D toxicity or sarcoidosis, where you have these macrophages that activate a vitamin D precursor. It could be in the background of renal failure, where they are going to be retaining the phosphate, and this sometimes leads to a type of hyperparathyroidism that is known as secondary hyperparathyroidism. In terms of cellular aging, remember everything is going to age at one point and it eventually dies. And as the individual person actually ages, even their cells age. The cells are going to be progressively decreasing in function, their lifespan is going to be decreasing, their functional capacity is going to be decreasing, even their resistance to this oxidative stress is going to reduce. So with age comes different physiological, even structural alterations, and there are various mechanisms that are thought to be responsible with cell aging, because if you stop the cells from aging, you can actually live forever. So things like DNA damage. So sometimes the DNA is going to be damaged, it's going to be repaired. But you reach a point where this DNA damage persists, and it may begin to accumulate in the cells, and it may contribute to the cells actually aging. And remember, some aging syndromes are going to be associated with defects in the DNA repair mechanisms, such that the lifespan of the experimental animals in some models can be increased if the response to the DNA damage is actually enhanced, or proteins that stabilize the DNA are introduced in this particular animal. So there is a role of these free radical damage that is seen in aging in this mechanism, although it still remains controversial. Sometimes there's a decrease in cellular replication. Remember, after a fixed number of cell divisions, the cell actually is going to arrest in a terminally non-dividing state. So we call this as replicative senescence. So it's going to be attributed by shortening of the telomere, and even in conditions like Werner syndrome, where there's premature aging, it may be due to a defect in DNA replication. The third mechanism is what I told you about, accumulation of this metabolic and genetic damage. So you have this reactive oxygen species that accumulate because of exposure to radiation, a reduction in the antioxidants that are available, such that oxidative damage can actually contribute to cell aging, which is why most of these anti-aging medications, you will see that they'll flash a lot of these key terms like this consists of antioxidants, but in my opinion, I just think those things are just scams. I really hope you enjoyed this video on intracellular accumulation. If you did, consider subscribing to this channel, hit the bell notification icon so you never miss on such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.